Wow, that was a kilogram of information. So thanks very much for this beautiful work and what you presented. Of course, there are quite a number of questions, that keep lingering. But the most interesting thing I've heard that whoever declines to consent elsewhere comes to Mlago. So I don't know whether Mlago, Nelson Frederick. I don't know whether Mlago is where every reject everywhere gets to. So thank you. And of course, from all this we've had, and quite a number of questions still linger, what should be done in the midst of all these challenges? We all know there are challenges. It's like telling somebody to go to a window and try to get consent from somebody, okay? Whereby actually you don't even have any private room where you can have that. And these are patients who are, already bedridden. Some of them actually, cannot even talk for themselves. So how do we balance saving lives with, upholding patient rights? Of course, another question, who should obtain the consent? We've seen that in one hospital, it's the nurses, but do the nurses really understand the complications? Okay. Then what should an ideal consent document look like? So those are just a few questions to stimulate you and provoke debate, because we would like to open this presentation to to discussion, please. I can see there are quite a number of surgeons in here, and many of them do emergency surgeries. So I would like to open the presentation to discussion. So you put up your hand, mention your name, what you do, then you ask. So we'll take questions in a batch. We'll start with 5 questions. So I'll start with Nelson, Frederick, then John.
Olivia, for that presentation and dissertation. I just have a few questions. Discussion. What I call redundant consent. If somebody comes to you and says, I have come for and then you begin saying, well, you have to consent. How does this person look at you? He says, I'm the one who has come to you. I said, I want these. Now, why are you bringing me into this discussion of consent? Another similar term can be the implied consent standard. Are there situations where we can use that? The mere fact that somebody runs out of his home and comes to me for help implies that he or she has consented. Are we going to trash that? Then I noted that in your study, you try to look at consent as a single event. But many times we know that consent is a continuous event, including context of surgery. I know that surgeons have had cases where after opening up people, they find things different from what they had set out to do. So what do surgeons do? You went in for hysterectomy, but you go in and you find actually this person had Turner's syndrome and he had no uterus, and yet you had consented a person for removal of uterus, which was not there at all. So the issue of within the framework that you want to develop, how do we bring in the concept of continuing consent? You assume in your study that you are dealing with the competent persons. Would this study be different if the participants were incompetent? Children, for example, mentally ill patients, those who are unconscious, and like what framework would we be talking about? Then my last question to you is, you seem to, okay, not seem, you did the study in the context of hard copy consent. But right now, with the exception of Mulago, most of the hospitals have moved to electronic data collection procedures. One would want to know, what would your proposals, how would they hold when Mulago moves to, fully moves to digital? And how would, for example, the issues of documentation be done? How would patients be documenting their consent within the digital world and all that? And would your suggestions then still hold water if you largely did yours in a hard copy context, and yet we are migrating to, and allow me to ask the last question as I sit down, the concept of moral distress. Moral distress is where people know what to do, but they can't do it because of institutional factors. Could it be possible that a whole bunch of these doctors, nurses, etc., know what to do, but the situation makes it impossible for them to do it, and they just say, let me just do this and the other. Thank you.
Okay, thank you. So after John, there is a hand online. Professor Mayer's hand is up. So after John, then Professor Mayer, then you'll answer. Then we'll take a second batch of questions.
Thank you, Dr. Maka, for the opportunity, and I want to congratulate Dr. Olivia Kituk and the team for successfully conducting this study and reaching this stage. My question begins from the remarks that were given by your lead supervisor, Dr. Garokande. In his submission, he admitted, of course, that consent for surgery is very important and it's required. But his experience at Kiwoko, and which is the experience everywhere, suggests that consent, standard consent, as it is described, is more of an ideal thing, especially in our cultural setting and other social economics circumstances. People don't understand English. Medicine is practiced in English. Patient load is too heavy. It's emergency. You don't have enough time. Something must be done. Compared to other countries where we got these practices of consent, whereby if you are in the UK, if you are in America, then you speak English. So getting that information is very, very easy. So considering the circumstances in which you people conduct these surgeries, and then what real standard valid consent requires, what sort of adjustments would you propose to the standard consent to make sure that it is consistent, that it is adapted to suit our socio-economic circumstances? Because you were proposing in the recommendations that there can be interpreters in hospitals, so that if someone does not speak English, there is a mkonjo somewhere around the corner ready to interpret for the fellow mkonjo, you know? And I think that may be difficult, considering that now that is another cost implication on the health system. The system is already so constrained in terms of resources. So that proposal is also idealistic. So given the data you got and your experience as a surgeon, what sort of compromises would you suggest, if any, that we can make regarding the requirements of valid consent that will make it easy for patients not to lose out on the services they need, and the health institutions and the caregivers do not unnecessarily incur legal liability when things go wrong? Thank you.
Okay, thanks, Dr. Walgohari. Just for Dr. Mayor online, please, you can go ahead and ask your question. Your hand is up.
Yeah, thank you, Dr. Olivia Chituka, for an excellent presentation. I think you and your supervisors are on the pathway, the sort of research to policy pathway. I have, I don't know, comments, questions. So 3 things. One, I don't know whether you have read Dr. Atul Gawande's book, Checklists, the Checklist Manifesto. And if you haven't, I would suggest that you do. But I in the context of the emergency consent, I'm just wondering whether, as part of your recommendation, you might think about having checklists that are actually documented as part of the consent document, just to make sure that whoever is part of that consent process, has a reference. I know it's easy for people. There's an option of just checking off what you probably haven't discussed with the patient or their relatives, but I think it's something that you might think about doing. Number 2, I'm not sure where you are in terms of, I know this was a step in the direction of eventually getting the research to policy and guidelines. But I'm wondering whether there is, you have thought about engaging with the technical working, if there is a technical working group, at the Ministry of Health. And I imagine this would be sort of in the, I imagine the Directorate or Department of Clinical Care. But I think that's something you should think about. I mean, the reason I say this is there's a pathway that one would follow in attempting to get your research eventually into the policy guidelines of the Ministry of Health. And so I think it will be important for you to think about the technical working groups. We've gone through this process before, and that's something we're willing to help provide some little experience on. The third thing, Mulago, I am not very familiar with the ISO standards, but I am just wondering whether, Mulago, I know, recently obtained ISO certification. I'm not sure which number. But my question is the process of emergency informed consent sort of part of that ISO certification? You talked about observing exactly what happens during, it is part of research, but in normal practice, I'm wondering whether, in order to obtain ISO certification, this is something that should be explored as well. And broadly more of part of quality assurance in the hospital. Thank you.
Okay, thanks very much. So, Dr. Chituka.
Thank you all for the very interesting questions. And many of those questions still remain questions. When you do something and it's like you open a can of worms. when you scratch the surface and then you start getting deeper and you start seeing how deep the problem is and how far it goes, this is just one of them. But I'll start with Dr. Nakwagala's question about the issue of implied consent and the redundancy of consent. When you look at the Mulago documentation, when a patient comes to the hospital, a lot of times that there are some forms. There's a yellow form that what I'll call it the informed consent form, but it's more almost pointing like an implied consent form. It tells you that you agree to all the treatment. It doesn't necessarily even talk about the surgery, whether it's surgery, whether you're going to have anything even more complex than just tablets and injections. So that is not right. And we have seen it from this study. We found that actually the patients want to know more. They feel they have to be able to make choices on what kind of treatment and more detail and more information given to them. So just because a patient has come and presented themselves, it is clear that even when they have come and presented themselves, they still want to have the right to choose what they're going to be, what's going to be done, and to allow to have things done to them. So in this case, to answer your question, we do not want to use implied consent, because with the implied consent, there's an assumption that the patient's rights are being respected, when probably they are not, because the patient, just by coming to the hospital, does not necessarily mean that they have actually consented to everything that they have done. You see where patients came in and once they're told what they have to do, they change their minds. So you can't assume that because the patient came, is ready to take everything that is going to be done to them, more especially something as invasive and probably life-changing and life-altering as emergency surgery. So in this case, the consent is not redundant. We do need to go ahead and get that permission. This is also just evidenced by how much when litigation comes about, a lot of litigation comes about and the patient, one of the things that comes out is, I didn't know. They did these things without me knowing. And if we are going to rely on implied consent, then you end up in such pitfalls. Then, as I did this study, we looked at it as, we were looking at it at more or less a point in time. This is in reference to your question about informed consent being a single event. What if things change? Do you still have to consent again? And one of the things that comes about to go around that problem comes about in the disclosure component of the informed consent process. When you're disclosing information, you're talking about the risks, you're talking about benefits, and that is where you bring out some of the things that could happen. And at that point, you get an understanding that this can happen, and it allows you, it gives you the confidence to go ahead and do what you have to do in the event that that happens, because you have already told the patients or the next of kin about the possibility of the unlikely events. The challenge comes about if it is something that you have not mentioned. So when you get to the end, in such cases, especially when it is totally unexpected, there is room for what we call deferred consent. So you'll find that they'll have consented for something that's already been done. But in most cases where possible, we've had cases where you stop the operation, go out to the next of kin, and you're able to ask or to tell them, this is what has happened. That is where even it becomes more important for the patient not to be on their own. There's always someone else who is also able to make decisions for them. The challenge comes about if the patient is on their own, was able to consent, but now they are unconscious, they're on the table, they can't consent, then it becomes, that's where those are some of the challenges that we have to figure out how to work out. In some places, they have this something on the consent. There's a form of consent called the emergency consent, which is at the discretion of the most senior doctor and allows that person to make a decision for the patient in the interest of saving their life. And this is supposed to be done in consultation and evidence that it's not made by one, the decision isn't made by one person. It's also made by the person who is probably most senior. An example, a surgical resident goes to operate and gets into the operating, opens the patient up, finds some other problem, and probably now says, God forbid, that now we have to amputate. For example, we have to amputate this leg. And the patient is going to be awake to allow for that. The patient did not consent for that. He did not mention it amongst the risks or complications. At that point, that is when that resident is supposed to consult the senior person on the team. And there's a discussion made and it's documented that that person was consulted and this is what the decision was made. And it was in the interest, it was judged to be and in the interest of saving the life of the patient. But that comes out in having the ability to have a consent form that allows for such documentation to be represented. In terms of the patients, my findings in patients who didn't have the capacity to consent, if I had looked at patients who didn't have the capacity to consent, I tried to go around that by looking at the next of kin. So that's why I was trying to interrogate both the patient and the next of kin. The next of kin presupposes there are people who are going to be providing consent for a patient who is not able to consent for one reason or the other. Either they are a minor, or they are unconscious, or they have mental illness. But I must say that especially for, there's a lot of things that are starting to change in terms of consent it has been mainly in the area of research where, for example, minors, you have the issue of assent. They do have a right to, or children from around the age of 7, it varies in different countries, but from around 7 to 18, you should get their assent before you're going to do anything. So that component is also coming in. And probably if we'd done the research in forever minors, would find that they also have their own rights. They feel they also have to express themselves. And we are now talking about a generation that is informed, that is more aware of their rights. They are more forthright and want to stand up for themselves. So even in that case, even when they're getting care, it's only fair that their input is obtained. Maybe that's a good point. Maybe even our consent forms should now start thinking about having an area of assent for minors who are at an age where they can understand what is going on, but are not legally adults. As far as those who are unconscious, we still rely on the next of kin. And that's why it's so important that the general public knows that they can be a next of kin, but also importantly, they start appreciating getting information out to their would-be next of kin. So I don't know how many of you here have a true next of kin. A true next of kin is someone who knows your wishes, is able to put that information out and respect them and knows what you'd want to do if you are in a certain situation. Your likes, your dislikes, someone who knows that for that person does not ever want to receive blood. Or that person does not want to have scars. For them, they'd rather die than have a big scar from up down. So if you're going to operate, and you're going to give a big scar, live, they'd rather die. I've had patients who are like that. They say, I'd rather die than have a colostomy or having to pass through from here. You'd rather leave me. And if the next of kin doesn't know that, they will go ahead and do everything and be very happy. And you wake up with a patient who is very angry. That brings out also the aspect where I think that we now, in fact, as a follow-on to this study, I was thinking that at some point we do need to look and see how patients, if a decision made by a patient disagrees with the patient with a decision made by the next of kin, sometimes you find that there are differences and you'll be surprised. Now, in the area of digital data, we are going electronic almost everywhere. I'm not sure whether consent, especially in such a setting, may be able to go down that route. It probably will. I don't know what's happening in the developed world, but even then, that is a lot of assumption that the population can read, is literate, they have access to the digital devices, and they're able to comprehend, because a lot of, once this information is digitalized, there's also an assumption that the patients or the participants have a good ability to read. But as it stands, we need to, I don't see that happening very soon, but in the process, we can, once we have a good consent form that is in the hard copy form, that can be digitalized. Possibly, I'm seeing, even now that you mention it, there's even a possibility of having this digitalized information, audio, so that we won't have issues of a participant saying that, read to me, because they can't read. For those who can, there are many options, many possibilities once it's digitalized. But yes, it is something to think about, but in the process, you need to have the basics right from the beginning. And that, how it is delivered, can always be worked upon, but the key components must remain. As far as moral distress is concerned, it is true that part of the stress that someone feels of not doing what is right, for example, the emergency staff, they did mention that they have issues of time. Then they talked about the documentation, because at the end of the day, much I will disclose risk and all that, there's no evidence that actually said that. If you look at our consent forms, it is just, I agree to be operated and I've understood the risks and benefits. Sign, finished. In many places, that is changing, especially in the private setting. The consent forms, there's a danger, unfortunately, that our consent form will become like a booklet with so many things. But we try to make it in a simple way and try to show the documentation of that, of all those things that you're talking about, the risks, the benefits, what you've actually told the patient. And to take away that issue of having the challenge of not doing what is right because of the circumstances around you. So our job here is to try and take away that issue of moral distress arising from the institutional challenges that are there, and try to address them to minimize that problem. As far as the standard informed consent, being idealistic, that is Dr. John. It is true that it does sound idealistic, but it doesn't take away the fact that we need the key components, the key things, and those key things remain: voluntariness, disclosure, and in terms of risks and benefits, documentation. However much, whether you're in Nakapiri pit, and this is evidenced by the patients themselves, they do want that. It's not like we are just putting some thing that has to be done because it has to be done. The patients actually expect it. They want to have that ability to exercise their rights and their autonomy, and to have that, and we have to be able to document that. So this whole study is trying, one of the things that it helped, I think, helped to bring out is the importance or the need, that the appreciation that informed consent is actually still needed. It's not something that we should consider an ideal. We should consider it the normal and not think that we are doing people a favor, but it's because it's their right. And those key components of that consent process should remain. How we can adopt it is one of the things that this study is coming about. So we can see it's already deficient. So it's deficient even in the perspective, from the perspective of the users, the beneficiaries, the patients. So we know that they do want to know about risks. They do want to know about what is going to be done. They do want to know who is going to do the procedure. Those are some of the changes that we are thinking about when we are making a better document. For Professor Mayer, about checklists, yes, the checklists remain. There are, in fact, some, for a patient who's going to theater, there are some checklists of whether the patient has got earrings, whether they have got fake teeth, if their blood pressure has been taken. I think even in that checklist is that consent has been provided. But what we want to avoid is that you just have a place that ticks and doesn't actually say what information has been given. And that is why beyond the checklist, the consent document itself should have more detail and should have those components in there so that the person who is seeking consent knows that on the informed consent, it says, I have explained the risks for the procedure, which are, it then forces me as the emergency staff to make sure that I have actually told the patient about the risks. I have explained the benefits, which are, and then you're able to also to ensure that benefits are actually communicated to the patient. Then in terms of engaging the technical work group in the Directorate of Clinical Services, this meeting, unfortunately, this period is a very busy period. There are so many activities going on, but this meeting was a first step in engaging the various stakeholders who are involved in trying to make this happen and to help with the informed consent documentation and processing to improve that. And we have engaged the Directorate of Clinical Services. They are aware of the work we've done, and we intend to move forward and find ways of working with that technical and engage that technical work group to see how it can work out. That is why when I talked about the call to action, and I talked about advocacy and the Ministry of Health, the advocacy is starting here, but we have already started making inroads with the Directorate of Clinical Services, because some of these things, they just don't even know what's going on. It only comes out from this work and presenting it and to the public that these are the challenges and we need to address them and see how best to do so. So definitely the Directorate of Clinical Services is going to be heavily involved in helping to work out a better informed consent process. As far as ISO certification, I'm not very sure what the real components of that ISO certification. I'm proud, we're very happy to see Mulago being given that certification, I think about 2 weeks ago. And I'm now also interested, you've piqued my interest in trying to find out what were the standards that were considered, whether informed consent was one of the issues that was brought out. But otherwise, nationally, the other policies that are there about informed consent are there in the Patients' Rights and Responsibilities Charter. There are also something within the Medical Council guidelines on informed consent, but these are more or less general for treatment, medical care. And they don't necessarily, they're broad. They don't narrow down to consent in an emergency setting. And I think this is an avenue for us to have them included in these guidelines and to see that it helps to drive policy in that direction. Thank you.
Thanks very much. So for many of you, please, Rose, don't be in a hurry to go. So many of you who are surgeons, I mean, even clinicians, you find that actually the way we administer or obtain or solicit consent in the hospitals is leaves a lot to be desired. So basically, you know that yellow form, basically there is no information whatsoever. And this is, I believe, all public hospitals, unless I'm not informed. So I think we have a lot of work to do, a lot of advocacy to do to ensure that actually we improve on the consenting process in our public sector and even the private sector. So do we have any other questions for? Yes, Adeline, and then Professor Cheng, then, okay, then Deborah. Adeline first.
Thank you so much, Bro. My issues have someone been highlighted on. However, I'm going to highlight some policy implications, which I feel you should put across maybe to the technical working group as you meet the Ministry of Health. So number one is the issue to do with the consent discussion privacy issues, because you highlighted the issue of our crowded settings. So, and I want you to consider a dedicated consent or counseling space within the emergency unit, because this aligns with the patient's rights to confidentiality and dignified care. The other issue is about scenarios where consent is difficult. For example, the incapacitated patients who cannot provide consent. How do you plan to handle that? How do you plan to implied, I will call it implied consent? Is it accepted? Can the steps be clear, highlighted, so that there is uniformity when it comes to handling that? And then the issue of training has not come up as a way forward, although I'm aware there are so many avenues where this can happen, because then that will improve the communication among health providers. Audit the consent quality checks. I don't know whether you're thinking about that. Reduce the consent gaps. Yeah. And then finally, for the clinicians who want to act in good faith during emergency, how can we protect them or safeguard them in circumstances where maybe there are fears of litigation or judgment, just in case they don't conduct the consent in a proper way? I'll end it there. Thank you.
Okay, good morning. And thank you, Dr. Chituka, for the presentation. I'm just following up on this last talk you've been giving, particularly for the case where you talked of emergence and there is no next of kin. And you gave an example. For example, you're in a theater and you realize you need to perform some big decision. And you say the junior consults the senior and so on. But I would have loved to stretch it to, for example, casualty. Patients are brought in by police or by anyone, and they need surgery. Who should make such consent? Is there a policy in the hospital? Is there a law? And who is the most senior anyway? When you say the senior makes the decision, suppose it's an intern doing the operation, and then there is a senior house officer as most senior. Is that one the most appropriate to make a decision? I think we need to debate it further to stretch it to what is the hospital supposed to do in this particular case? And who is senior in that level who should make decisions? Not anyone who is better senior to the other one, but the seniority in the rank with the hospital and the institution. We should be a policy, we should be a law, we should be part of our code of conduct in the practice. Then the next of kin, yes, you talked about it because it's been grappling me a lot. You discussed it, but there's something I didn't really get completely. How do we know that actually this next of kin is the right person to make that decision? For example, we are driving and then I collapse and my driver brings me to hospital. And it's an emergency. Who makes the decision at that time? That driver of mine, the next of kin at that time to make a decision? We need to interrogate the aspect of surrogate decision making and see if there are possibilities of people who are, even if I have a next of kin, they may not be my decision makers. So there could be another decision maker somewhere who is a surrogate decision maker. That's the one someone I've delegated, and that's the one who has my interest at hand, and that's someone I trust with my decisions, particularly the health decisions and so on. And lastly, I heard you mention something deferred consent, which I don't know whether it should really come in a clinical practice. I know we use it in research, but that's a different setting. In a clinical setting, particularly surgery, I don't think deferred consent has a room, but you can explain and tell us what happened in your research. Thank you.
Thank you, Dr. Chitoka, for the good work you have done. Before I ask you read the question, let me bring a case scenario. As you know, litigation has become real, and the problem is not going to go anywhere. It's yet with us, and it will stay. Now, sometimes back, I had in Mulabuia, there was a case of a patient who came, brought in by well-wishers. He was very sick. He had a mangled limb. He needed emergency amputation to be done. And he consented, and the amputation was done. Thereafter, after recovering, the patient went home. He sat with his brother, who was morally, I can say, morally not upright. Then they planned a case against the doctors who did the procedure. And they went ahead, sued the people who did that amputation in court. That the brother said, the patient said he was very sick, he didn't understand anything, and the amputation was done. And the brother said he was around, he was within, he was never informed, only to find the brother's legs was already amputated. So they won the case in court. Okay? So is there in our law, they call it the ungrateful patient. Actually, after that, there are other cases of ungrateful patients. If you look for in penal code, they are there now. Those cases are there. I think there was one involving Ops and Gyne in one of the hospital. There was another one, I think in Mukono, something like that. Those cases have been coming up. Ungrateful patient. We have to be very careful about them. So they won the case. However, the only luck that came on the side of the doctor, the judge looked into it, said, look,
this doctor was able to save your life. And indeed, that surgery was really supposed to be done. The only problem the doctor made was not to get the right consent from the right person, the next of kin. So that was the only problem. And because of that, they were awarded some little money. It's like the current rate, maybe about 250 shillings awarded for that case. That's why they call it ungrateful. You won the case, but the doctor was also right. So we had that scenario. Now, in our unit, we always have a lot of problems. People have talked about it already, though. We are talking about unconscious, but we are missing one word: unknown and unconscious. And they need urgent operations. Did you come across such cases? And what is your view? How can we go around handling such kind of cases? And how can we protect ourselves from such cases happening? That's what maybe I want you to elaborate on. Thank you.
Thank you so much, Dr. Olivia, for the beautiful presentation and the very important study. So I have two questions. I'd like us to talk about the issue of a patient with diminished autonomy. So you have a patient who is in so much pain, maybe they are bleeding profusely, and all they're thinking about is going into the theater room. They are not thinking about the implications. They're not thinking about what will happen next. And the scenario is similar with, say, the next of kin. How will you ensure the rights of these patients are protected against the need for surgery? And the second question is around power dynamics. One of the recommendations from your study is for the doctors or the surgeons to be involved in the consenting process. The surgeons and as well the nurses as well. So my question to you is, what recommendations or what advice would you give to, say, fellow doctors or fellow surgeons as they handle this issue of consent? Because I imagine some other doctors may come up and want to conduct similar studies, but how should they handle the issue of power dynamics where, say, they need to observe the nurses are aware this is a surgeon, this is a doctor, and ensure the results that come out are not changed. Thank you so much.
Yeah, allow me to ask one more question, which I find burning. In a few years, we plan to have living donor organ harvesting. I know that we don't have a law yet, but I think the planners are supposed to be making a law for it. Many times these organs or donors can be approached during usual surgery for other reasons. And some people have abused the consent process for that, where say, in case we find this, we will be willing to have you sign up for this and that kind of stuff. I don't know whether the policies that you intend to influence should cater for that already, because it's a living reality that we are going to go into very soon. And looking at the lucrativeness of the business of organ harvest from living donors, I don't know what suggestions you'd make, what precautions, what steps the policy should do, emphasize in that aspect. Consent for living organ donation.
Okay, just one more.
Thank you so much, our teacher, Dr. Chituka, for the presentation. I wanted to bring this to your attention. In event of family conflicts, before or even after consent, how should someone move on? Because there are scenarios where a consent has been taken already and families disagree. A certain group says no to surgery and a certain group says yes to surgery. Yeah, I believe it also goes down to who should consent and which consent. Where do we, if the patient consented, yes, maybe that would be different from when the next of kin had consented for this patient. But in event of maybe minors, we had a case where we had the Jehovah's Witness. The mother says no to transfusion. And the father followed us in the corridors and said, if it is what is going to save my patient, please transfuse, but we are not going to document anywhere. And it was really a little tricky, though we still had to save this patient. Yeah, then the last component of maybe this is when can consent be withdrawn and how should we take it? As an MO, I practiced, and after the mother accepting to go for a cesarean section, asked us to consult the husband, and we consulted, to which they all accepted. 10 minutes down the road, the father came from the tomato garden with his boots direct to theater, picked the wife naked from the table after some guidance from other people that the wife could actually push. To a disappointment or to the good luck, they came back with a baby 2 days later and they asked us why we wanted to operate this woman. However much we had enough evidence that surgery was the best option at that material time. Thank you.
These are all very stimulating questions. And I like to appreciate that these are from lived experiences. This is not something theoretical. It is what people are going through. So thank you, Adeline, for the questions. Just to note that Adeline was also very instrumental in this work, and we actually have a publication that should be coming out in this month that we worked with together. Thank you, Adeline. When you talk about, you're talking about policy implications and the issues of, rightfully, the issues of privacy. As I showed you in that slide, there's no privacy when you're going to give the consent. And these are some of the details that we start thinking about in providing a room where this consent can be done. Part of the challenge of that in an emergency unit is that the patient is on a bed and to go and get consent means moving that bed to another place. So the technicalities may be a bit different, but at least an attempt should be made to provide privacy. If it means providing screens, making those available, but it should be an intentional thing to think that privacy is required. So those are some of, I would call them the granular details on how to go about making the changes with the consent process, which can be hacked out as you're working out with the technical work group, not just the documentation as in the consent form, but even issues about the environment. Then for incapacitated patients, those still remain a challenge. And one of the things that this question about incapacitated patients, some of it is coming out in other areas from other questions, but that is where you'll find there's that role of the emergency consent component of the consent document, whereby there's no one around to consent for the patient, but it has to be taken into appreciation that someone who is senior takes me to the question of who is the senior person. In terms of seniority, it's not senior in age, it's not senior in experience, but is senior. This comes down to the institutional level. As an institution, we do expect that you have an emergency call team. So the team that is on the emergency call has different levels of seniority. This is the point where it has to be clear that the person who is senior, in that case, that's usually the consultant who is overall in charge. In the absence of the consultant, the head of the accident and emergency unit. It's not the senior between the two of you who are standing there, the intern and the SHO. No, that shows you the importance and the gravity of the decision that you're going to make and the implications. I would have very much loved to hear from the legal fraternity. They were invited, but as I said, there are so many conflicting programs taking place in this season. But from the legal point of view, there are a lot of things that are coming out in terms of who is the next of kin, who has the right to have made a decision for the patient. That is why we also needed a lot more of public education, even amongst ourselves, to know who are those next of kin, who are the surrogate decision makers, who can make a decision for you in case you can't. We need to be able to understand that more. And that comes out into the training of health providers. And the training should be at an institutional level, because you know the people who are going to be involved in, if there are problems. For example, as Mulago, you find that you're having a training which involves even the legal arm of the hospital, because they know what problems come about. And those are also incorporated into how we actually do the consent to make sure that it is legal, so that you don't have problems like what Dr. Okello was talking about, where someone consented, then he says, I didn't consent, or I didn't understand, or how do you, or I wasn't told, and there's no evidence that you actually, because with the law, they will tell you that they'll take things according to what the evidence shows. Is there any evidence that you told this patient that there was this problem going to occur? Is there any evidence that there was no one around and you consulted? So those are policies that have to be clearly made by the institutions, but also at a national level because of the public hospitals. And then these are supposed to be continually given as information to the emergency staff. So it's not enough to just assume that everyone who is working there knows what to do, because there are some things that are changing, and then there are, and as I said, this is a teaching hospital. The people who are working in the emergency unit keep changing. They're not there for 10 years and they know everything that has been happening over the last years. So each time they come in, they need to be aware of these areas. Then the issue of protecting someone for acting in good faith. Again, it still remains, it comes back again to what I would like to call it the emergency consent part, where there has to be documentation and proof that there was no one else able. Because unfortunately, when you go to a court of law, the evidence is not there. And you cannot, at that point, it will look like you're acting on your own interests, even if it is so evident like that you did this to save the patient's life, and then afterwards they change their minds. When you have that documented, it also makes it difficult for someone to come back. So someone, if where possible, you have that institutional policy that is given all the way from the ministry to show that this is allowed, that when there's in an emergency setting, this has been done. However, it should not be abused. The challenge is having it abused, where someone says that, instead of endeavoring to get the consent from the various people available, just says, cut a long story short, let me just sign for this patient. and we go ahead and do the procedure. As much as possible, there should be evidence that attempts are made to try and get the people who can consent for the patient, surrogate decision makers, and in the absence, it is then the senior person on the team in conjunction with the team that's going to work. So that needs to be, there should be some document showing that, a policy that will guide the emergency staff so that they are protected. Then the issue of who is the next of kin. How do you confirm who is the next of kin? That is difficult. And I don't know how we can go about that. I would have loved to hear from probably the legal fraternity on what, whether that person is a true next of kin. It is indeed a challenge to know who is the next of kin for you as an emergency staff, because whoever is around, you can see from even the research, there were people who signed, but they are not related, but they just happen to be the ones who are around. So it takes us to having to be able to define who is considered the next of kin, so that we as emergency staff know what questions to ask that will show that this person is the next of kin. But also, we need to appreciate that the next of kin is much broader than the next of kin as we know it. Yes, Dr. Nakoga.
Next of kin has been legally defined.
Yeah.
And then what you need to discuss is what we call the hierarchical order, because there are issues with reasonable availability. So what some jurisdictions have done is they describe that the next of kin will be the following hierarchical order, depending on availability. So for example, they can say, like, the spouse is the first next of kin. In the reasonable unavailable spouse, the adult children come in next. In the absence of the adult children, then your parents come in. In the absence of your parents, your grandparents. In their absence, your friend. And this is legally defined. And I think what is missing in Uganda is for us to generate specific laws that can answer those exact situations. So if you come into emergency those are kind of questions that would be, when the patient is being admitted, who is your next of kin? You document it. Is he available? No. Who is next? So that can be done if we are serious about formulating this kind of laws. And I think it's only when we get that level that we shall seriously be ready for some of those constraints. But what we are doing now is kind of a legal gamble, where even the person who brought you becomes the next of kin, and that's not acceptable. You know, right now, if anybody collapses here, we automatically next of kin. Yeah, so that's not acceptable. But I think as you work with definitely you have to work with the legal fraternities. They have to bring it back.
Okay, thank you. I think we are living, it's a ticking time bomb. And I think for those who don't know, Dr. Okero is in charge of the accident and emergency unit in Mlago. And actually there is a need to protect, to protect the health workers, especially in a hospital like Mlago, whereby at any one time, something is missing. A doctor is going to be sued because something is missing. And some of these things, actually, it might be as something as simple as a pair of gloves. A bleeding patient, you don't have gloves, they do not have the capacity to go and buy their own gloves, and you look at them bleeding to death. So the thing is, I think hospitals should sit down with their legal departments, look and search the law, and identify provisions, okay? So that they come up with either treatment protocols, standard operating procedures or algorithms that in case of such a situation, how do we go about it? You know, he talked about amputation without, without consent. It happened to me, when I was up country. And of course, exactly, I'm not sure whether this is written somewhere, whether it's international best practices, whereby at least two consultants or senior health providers, senior doctors, once they concur that, yes, this is the best, in the best interest of the patient, this is what should be done, then they make the decision, well documented, then the head of the institution of the hospital signs and gives the attending doctor permission to go ahead with that procedure. It's written somewhere. I don't know where it is written, but these are things that need to be clear so that even patients know that, yes, this is the procedure. So I think we'll end it here. It's coming to midday. Thanks very much, ladies and gentlemen. Okay, you have one thing to do. Okay, thank you.
There was a burning question that Dr. Nakwagala asked about living donation. I'm deciding to talk about it because it's a hot topic and eventually it is going to have to come into play, even for emergency consent. The truth is, yes, patients come in an emergency setting, they probably, for example, they are going to die. They're already brain dead, and there are going to be issues of these patients who are potentially donors. Now, in many countries, those issues have been, I would like to acknowledge Dr. John. We are doing a study about issues of living donors and the issues of presumed consent. So there are some places whereby, in some countries, I think in Europe, they have, this is national, and that's why this is something that is at another, it's not just institutional. It's a national level, guided by even their laws of the organ donation and transplantation. So the average citizen, if you get into an accident and you are potentially, you die from non-natural causes, but your organs, other organs are still okay, it is presumed that you are willing to donate your organs to other people. However, there's something called an opt-out. So in the consent forms, there's assuming your next of kin knows your wishes, says this person doesn't want their organs to be given. You sign that I have opted out to giving my organs. Otherwise, it is presumed that you are willing to give your organs. So for them, they have an opt-out option. In other places, they have you opt in. In other words, the point is that the consent form has that component. Are you willing to donate your organs? Or are you willing for your, are you willing, as far as the next of kin is concerned, are you willing for your patient to have their organs donated? Yes, no. But otherwise, in some other places, it is, I am not willing. If you don't sign that, it's assumed that it is. So that is going to be a component. Yes, it becomes almost like, in some places, it's just that if you're not careful, you don't read those consent forms, you go tick, 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 and you're saying, yes, yes, yes. Like some of you, when you're filling in visa applications, then you write, no, 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 no. When sometimes an answer no is bad. You have to be careful. Of course, the assumption is that you have read the person who is involved has some literacy level. And that brings out the component of having those consent forms explained to the person, because many of them are signing things that they don't know. So yes, consent is very dynamic. There are going to be things that keep coming. And I like the idea that Adeline talks about of routine audit. and quality checks. It's as important as, because you can see things are changing. The consent that I was doing when I was a student, the few times I did it, was just, I agree to the operation at best, and they signed somewhere. I didn't know the element of risks, benefits, and all that. Over the time, that has come up. Now we are going into an era of organ donation and things like that. We are going into digitalization. So those changes have to be brought in at some point. And the only way you can have that is having those regular checks to see that the consent form is actually meeting their needs and addressing the issues that come up. Thank you, everybody. Please join us for a small refreshment outside.